Okay, so I want to do this video on transfusion medicine because there are really very few material out there, and it's very important for all competitive exams. So let's just start off. So basically, blood has various components. It has like it can be whole blood, or it can be red blood cells, platelets, or white blood cells, clotting and clotting factors like cryoprecipitate, and plasma. Fresh frozen plasma has everything in it. Basically, it has plasma proteins, coagulation factor, protein C, protein S, antithrombin 3. So you need to know the indications of each. So when will you transfuse whole blood? Whole blood is not only PRBC. This is PRBC. This is platelets. In platelets, you have SDP, single donor platelet, RDP, random donor platelet, or multi-donor platelet. So when will you transfuse whole blood? What's the indication to transfuse whole blood? In acute massive bleeding, you need to give whole blood itself. You don't need to give RBCs, or in open heart surgery, they give whole blood because they lose whole blood basically, and the components are red blood cells, white blood cells, platelets, and plasma. Now, we don't like giving WBCs unnecessarily, so that's why most frequently we would like to give PRBCs in everyone. And PRBCs, 1 unit will increase the hemoglobin by 1 gram per deciliter and increase the hematocrit by 3 approximately. Now packed RBCs will have red blood cells, there will be some white blood cells, and there will be some plasma. Platelets we will transfuse if the platelet count is less than 10,000 on average, or if you have any major surgery or minor surgery. Major surgery 30,000 is the cutoff, minor surgery 20,000 is the cutoff, otherwise 10,000 is the cutoff. Bleeding manifestations can start anywhere up around 10 to 20,000. You don't know, it's just not clear, but yeah. So basically those are the components of blood. Now when you transfuse blood, or when you frequently transfuse blood also, you can have reactions. So basically it is like very similar to allergic reactions. So I'm trying to kill two birds with one stone, and that's a classification of adverse drug reactions, classification of allergic reactions, and classification of post-transfusion reaction, and also post-transplant reaction. So basically we remember it as A, C, G, A, C, I, D, right? So that is how we remember transfusion reactions. A is anaphylaxis of preformed IgE. IgE antibodies, or Ig like preformed IgE antibodies is what causes anaphylaxis. So IgE will activate the mast cell and degranulate the mast cell and cause mast cell degranulation. So that is type 1, or the anaphylactic or allergic reaction. And with this type 1, what happens? It happens within minutes to 2 to 3 hours, and inflammatory mediators are released and degranulation of mast cell happens, and it clinically presents as urticaria, pruritus, anaphylaxis, wheezing, hypotension, respiratory arrest, and shock, but there will be no hemolysis here. No hemolysis in allergic or anaphylactic reaction, so just know that it's not a hemolytic reaction. But then you can have acute hemolytic transfusion reaction, which is, again, it is a type 2 hypersensitivity reaction, that is the IgG-C. Cell mediated toxicity. So IgG will come, the host IgG will attack the transfused blood cells and cause hemolysis. And when you have hemolysis, you take the plasma and you have red lysed plasma, and so that is acute hemolytic transfusion reaction, and that happens within 24 hours of transfusion. Due to preformed antibodies, you will have fever, hypotension, tachypnea, tachycardia, flank pain, hemoglobinuria, back pain, classical back pain here, and then you can have jaundice, and so these are the anti-A and anti-IgG antibodies. So that's AC. Now you can have a febrile non-hemolytic transfusion reaction. So febrile causes fever, but there is no hemolysis. What can that be due to? That can be due to cytokines which accumulate in the RBCs, or that can also be due to infections, or it can be due to anything that causes fever. And this happens within 1 to 6 hours of transfusion. You get fever, headache, chills, and it's more common in children. So the donor WBCs release preformed cytokines stored in the blood packet, which causes the reaction. And then transfusion related acute lung injury called TRALI. There is neutrophils are sequestered and primed in pulmonary vasculature, and neutrophils are activated by a product, anti-leukocytin in the transfused blood, and release inflammatory mediators, increase capillary permeability and pulmonary edema. So basically, when we give blood, these neutrophils are sequestered in the pulmonary vasculature. So pulmonary vasculature, you have neutrophils getting stuck over there in the pulmonary vasculature, and then these neutrophils are activated and they cause increased capillary permeability in the lung, and then you have pulmonary edema. Basically pulmonary edema, and it is non-cardiogenic pulmonary edema, very similar to ARDS, but this is not ARDS, this is transfusion related lung injury. So it can be confused with ARDS because very similar. And then you can have a delayed hemolytic transfusion reaction. Now what is this? This is a amnestic or a forgotten response to a foreign antigen, and it causes onset is after 24 hours, usually presents within 1 to 2 weeks due to slow destruction by reticular endothelial system. Is self-limiting and clinically silent, and you may have mild fever and hyperbilirubinemia, but nothing to do. You reassure the patient and discharge. So that is the thing over there about overview. So if you look at adverse drug reactions over here, you follow the same system ACID over here. So you see the A is anaphylaxis. Anaphylaxis is IgE mediated, and these cause urticaria, angioedema, and anaphylaxis. That's completely different. A, C, and G. So C is IgG mediated cell toxicity. I is immune complexes, so IgG plus antigen causes vasculitis, serum sickness, and drug induced lupus. And D, delayed hypersensitivity reaction, is ME. So delayed ACID, a cell mediated, or T lymphocyte mediated, has again 4 subtypes, 1, 2, 3, and 4 subtypes. So M, delayed M, is macrophage mediated inflammation. E is eosinophil mediated, and you can have over here morbilliform eruption or stuff. So that is a reaction to a drug, a delayed eosinophilic reaction or delayed macrophage-like reaction. Contact dermatitis is a delayed macrophage-like reaction. Delayed lymphocytic reaction, cytotoxic lymphocytes, and that is SJS and TEN. And you have delayed T lymphocyte neutrophil mediated, that is AGEP. So AGEP is acute generalized exanthemus pustulosis. So that is overview. Now when will you give WBC transfusions or like granulocyte transfusions? Granulocyte transfusions are given in severe neutropenia when the absolute neutrophil count is less than 500, life-threatening bacterial or fungal infections, or no response to antibiotics for at least 48 hours. In children, you need much lesser of these. So those are the indications of WBC transfusion. And so that's a quick overview of this. Now, what are the specialized blood products that you can give in transfusion medicine? So there is basically you can give irradiated, which is an expensive method, and then you can just do leukoreduced, which can be done by a filter. You can either filter it and leukoreduce it, or you can wash it. So in patients with IgA deficiency, anaphylaxis and stuff, you will just wash the transfusion. You just wash the transfusion products and remove all the proteins and you would prevent anaphylaxis in washed. Leukoreduced is when if you are chronically transfusing patients, you don't want to give them WBCs because WBCs will express the HLA class 1 and HLA class 2, and then what will happen is the recipients will have ready antibodies waiting, and then when it comes in, it can generate a C cell mediated response over here in this case. So you have all these methods over here to remove WBCs. You can leukoreduce them or you can irradiate it. So you need to when you irradiate it, you even kill CMV infection, and it kills donor T cells and prevents graft versus host reaction. Leukoreduction removes WBCs, granulocytes and stuff. So in frequent transfusions you don't want to give them. So basically when people have very frequent transfusions, you want to prevent alloimmunization. If alloimmunization occurs towards platelets and RBCs, we need to transfuse HLA matched platelets and RBCs, which then becomes impossible to find, and then the patient ends up dying. So we need to prevent alloimmunization in people with thalassemia major, or someone who needs transfusions throughout the entire life. We would recommend giving them leukoreduced. Leukoreduction is if we have less than 1 to 5 million WBCs per transfused blood unit, and some T cells escape. Donor T cells have no resistance and they start attacking the recipient. So basically that is what leukoreduction is all about. And graft versus host. So basically when you're transfusing blood acts like the graft, and then that starts attacking the host, and that's a graft versus host transfusion reaction. And it basically in severely immunocompromised people, you can see graft versus host like reaction in very commonly in skin, in liver, in intestine. And skin biopsy can be done to confirm graft versus host reaction, not only in blood transfusion but any graft versus host reaction. And in transfusion related graft versus host reaction, the T cells attack the bone marrow and cause severe myelosuppression. So in irradiated products, T cells become incompetent, and what happens is when you irradiate blood, there are no T cells basically, so you prevent this graft versus host reaction. And in the center of the blood packet, you need to give 25 grays and 15 grays in the periphery. If you must not give more than 50 grays, because if you give more than 50 grays, you will destroy the cells. So basically that is about specialized blood products. We irradiate to decrease T cells to prevent graft versus host reaction and graft versus tumor reaction, and leukoreduction is done to prevent CMV in chronically transfused patients and potential transplant recipients, to prevent alloimmunization, and those are about the specialized blood transfusions. Hemoglobin less than 7 is usually the basic indication for transfusion. And over here you have transfusion related side effects. So just a quick recap. So you have hemolytic transfusion reactions, you have febrile non-hemolytic transfusion reactions, urticarial reactions, anaphylaxis, TRALI and TACO, and transfusion associated sepsis. And then you can have delayed reactions like you can have hemolytic, you can have iron overload, viral infections like CMV, malaria, transfusion associated graft versus host, and prion disease. So those are the transfusion reactions over here.